I'm David Lewis. I'm a haematology consultant from Plymouth in the United Kingdom. My main clinical and research interest is lymphoma. I work in a centre that does a large number of early phase and first-in-human clinical trials, as well as large randomised studies. And I'm the chief investigator on the ENRICH study, which was presented at ASH, and also on the I'm joint UK chief investigator on the Oasis 2 study, which is also presented at ASH this year. And I work also at a major transplant centre and a CAR-T centre. Yeah, so I presented the ENRICH data, which was the primary analysis of a large phase 3 randomised study comparing ibrutinib rituximab to immunochemotherapy in previously untreated mantle cell lymphoma patients. And we were the first study in history to show an advantage for a non-chemotherapy approach over chemotherapy in this group of patients, with an advantage for progression-free survival of IR over R chemotherapy. I think with mantle cell lymphoma, this conference has, I think, reflected the movement of BTK inhibitors further forward to the first-line treatment. And I think we're on the cusp of looking at chemotherapy-free regimes for mantle cell lymphoma. We saw the ENRICH data, which I presented, showing the advantage of IR over R chemotherapy. We saw Oasis 2, the interim analysis of that being presented by Steve Le Guil, which actually shows, which is comparing a 3-drug triplet non-chemotherapy free with ibrutinib rituximab. So we can see a huge amount of enthusiasm for these clinical trials of chemotherapy-free regimes. And it does feel now that it's only a matter of time before we have a chemotherapy-free regime for mantle cell lymphoma as a standard first-line treatment. So, particularly regarding mantle cell lymphoma, I think, as I said, we're on the cusp of setting a new standard of care. I think in terms of future questions, what's clear is that we're really not doing very well with very high-risk blastoid patients. So we really need new treatments and new clinical trials targeted at these very high-risk patients, because we're currently, I think, failing them with our current treatment regimes. And the other major thing that we're going to need to look at is, when we're giving everybody first-line BTK inhibitor, what do we then do second, third line?